Yeah. Well, good morning and welcome. My name is Merete Nordentoft. I'm a professor in psychiatry at University of Copenhagen, and I've worked with suicide prevention on a national level for several decades. And the title of my talk is Turning the Tide, Experiences and Priorities in Danish Suicide Prevention. I know you have been very interested in how we have handled the COVID-19 pandemic and how it has influenced the suicide attempts and suicide rates, but sadly we do not have any data yet. What I can say is that we have continued with all the initiatives we had already in place, and we are working to get updated data on suicide attempts and suicides during the pandemic, but we don't have data yet. We know that the number of deaths in Denmark due to the pandemic is approximately 110 per million inhabitants, and it is rather low compared to countries like France, Italy, UK and Spain. We're working to prevent suicide, and that effort has continued during the prevention. What we are following the guidelines from the WHO, and I've here shown the two documents we are working with. Its mental health action plan and the report Preventing Suicide, a Global Imperative. In Denmark we have been rather successful in bringing down suicide rates, and that was why we were invited to write an editorial for Science a year ago, where we called it Suicide Turning the Tide. And it is because we have had a very positive development in Denmark, where we have had a steep decline in suicide rates for both men and women, most pronounced for women. And I think the explanations are the restrictions of dangerous means. That was, at least in the beginning, we saw a very good effect of that. And then in more recent years, we have focused on psychosocial intervention. But both elements would be in place all the time. And by that intervention, we were able to reduce the suicide rates from 18.0 per 100,000 in 1980 down to 11.4, which is approximately the number we have now. So it's a steep decline. We have the same distribution of suicide rates in Denmark as we have in many other countries, where we can see that men have higher suicide rates than women, and that elderly have higher suicide rates than young. Then we're working on suicide prevention at three different levels. We are working with the universal prevention, the selected prevention, and the indicated prevention, the model called USI. And I will go through some of the examples of what we're doing. Universal preventive interventions address the entire population, while selective intervention address a subset of the total population, especially individuals who are at greater risk for suicidal behavior. And then indicated prevention are targeted individuals who have already begun self-destructive behavior, so people who are more or less in the process of attempting or completing suicide. We view suicidal acts as a complication. It's a preventable complication. I think it's a very good way of looking at it. It's because it's not one disease. It is a complication to a range of diseases and conditions, and social aspects can play an important role. As I've already explained, we work with these three different levels: universal, selective prevention, and indicated prevention. I'll give some examples of what we're doing. With regard to the indicated prevention, which is for people who are already either thinking of suicide or have attempted suicide or in the process of attempting suicide, we want to make sure that suicidal persons could be quickly and correctly assessed and provided the necessary help, and that should be provided with a guiding principle, so that a suicidal person is not left on his or her own before other relevant support has started. And that can actually be somewhat challenging, because it is necessary really to guide people closely. So what we have in this area, we have suicide prevention clinics all over Denmark. First they were temporarily, but now they are permanent structures with a national coverage. And we have had a study where we examined the effect of those clinics, and we could see that they were able to reduce the number of suicides and also the number of suicide attempts. So we view these clinics as something important. They're not available in very many countries. I think we are somewhat unique with regard to those clinics. And it's clinics where people can go, whether they have a mental condition or not, and if they have suicidal thoughts or if they have attempted suicide. They can also be referred after attempted suicide. If they have a severe mental illness which is taken care of in some other part of healthcare, they should rather do that. So that's the target group. Yeah, what we could see was that we were able to reduce self-harm, suicide and death when we looked at the effect of those clinics. Yeah, and what have the clinics done during the pandemic? They have continued their usual practice. They have transferred some of their consultations to video consultations. And initially, when we had lockdown in March, there was a drop in number of referrals, but now it is similar to previous years. So I think it also took a while to know how it could work, also with the video consultations. Now they have both video consultations and physical meetings. We also have the Lifeline, which is an NGO, and they are open from 11 o'clock in the morning to 4 o'clock in the night, and it's volunteers who take the phone or answer the chat or whatever it is. There's a chat room also. And they had also an initial drop in referrals, and they also had difficulties with the number of volunteers, because in the beginning, when we had the lockdown, we were not allowed to, we were recommended to work from home, and in Lifeline, they want people to be present also to get supervision. So, but now they are present, and they'll just have physical distance between each other's, the counselors. So they are up and running the same way as they had before. And then finally, with regard to indicated prevention, we have something that's also rather unique. It is we have an acute psychiatric emergency outreach, which is a service that is available 24/7, where a psychiatrist is on duty and pick up the phone and decide whether it's going to be a physical outreach or a telephone consultation. And it's meant to solve severe crises. So it's people in severe suicidal crisis who cannot be persuaded to go to a psychiatric emergency room. It could also in some cases be people who have already attempted suicide, and where we go and bring them to the hospital where they can be treated for their injuries. So I think that's a rather unique and very important intervention, and it has been up and running all the time. There was no change in that. In the beginning we had a little bit fewer calls, but soon after it was just as usual. Yeah, and then as I mentioned, there would also be selective prevention for different target groups. I won't have time to go into all target groups, but I'll mention that in mental health services, of course, we have a lot of initiatives in order to protect that important group. I think people with mental illness are the most important target group, because it's a large group and they have the highest risk of suicide. So we have in place a systematically evaluation of suicide risk and decisions about which level are these people considered to be at. Are they in an acute suicidal crisis? Is the suicide risk somewhat elevated, or could it be considered not elevated? And everybody, all staff members are taught about how to evaluate suicide risk, and we implement this risk evaluation. It's also supported by our medical record system. So that's in place, and that has been running all the time, also during the pandemic. Then we have focused on also to make the hospital wards safe. We have worked with some very clever architects who have created solutions where it's almost impossible to hang yourself while you're admitted. So everything that can serve as a ligature has been removed. Yeah, and then we have implemented a lot of different treatment elements. Here I demonstrate how we implemented early intervention services all over Denmark. So now Denmark is covered with intensive treatment for people with the first episode psychosis, where they involve the families and have close contacts with the patients with first episode psychosis. We have something we call a crisis plan, which is developed both in early intervention services in the suicide prevention clinics and also in the rest of psychiatry. And it is about trying to find out what can you do in a critical situation. It's a collaboration between the patient and the staff member, and they identify what can be done to distract yourself. If I get in a suicidal crisis, what can I do to help myself without involving anybody else? Can I do something to get more calm, or to make myself thinking of something else? That's the first step. And then if that's not enough, you could call somebody from your network. It could be somebody from your family or friend, and or it could be and then the next level would be maybe an NGO or the psychiatric services. It could be, if you have affiliation already to an outpatient clinic, you could call the staff member who is responsible for your treatment, or you could call your doctor. And you could also go to psychiatric emergency room, or you could call psychiatric emergency outreach. So it's sort of a hierarchy where you first see what you can do for yourself, what can you do if you involve your immediate network, and then after that, how can professionals help you? And it should be rehearsed so that it is still valid when a suicidal crisis occurs. So it's not something you can do one time and then forget about it, and then it will serve. It will work well also after 1 year. So you should repeat it and revisit it. Okay, then we've also, on the universal level, we have also done a lot of things. And as I said in the beginning, I think that these initiatives were responsible at least for the drop in suicide rate in the beginning, because we had carbon monoxide in household gas was removed, carbon monoxide in car exhaust was removed. There were restrictions in the legislation regarding weapons, so there was reduced access to firearms, and the barbiturates, which was used as hypnotics previously, they were deregistered because they were too dangerous. And also the analgesics were, some of them were should be given on a special prescription, and some of them were put in small packages so that you would not have access to large amounts of dangerous drugs. And we also, as all over the world, implemented less dangerous antidepressants, the SSRIs, which are now used much more widely than the tricyclic antidepressant we had previously, and those were much more dangerous if you took an overdose. Yeah, packet size restrictions I've already said. And then right now we are monitoring suicide in front of trains, and we are evaluating what can we do to prevent suicides on train stations and also on the rest of the railways. Then we collaborate with the media, and I think it is, first of all, there's a set of ethical guidelines which can help to guide how to present suicidal matters, and then to collaborate in order to not to make it a taboo, but to produce both written and electronic reports that can be helpful, always with a guidance to where to seek help. Yeah, we have a lot of organizations involved. Right now in Denmark we are about to create a new plan for psychiatry, a 10-year plan, and I'm sure suicide prevention will be part of that. So all the different ministries, Ministry of Health, Ministry of Social Affairs, and Danish Health Authority, Danish regions, Danish Centers for Suicide Prevention, and then my institute, Danish Research Institute for Suicide Prevention, Lifeline, and private funds are involved in trying to help this matter. So we hope that we will be able to reduce suicidal crisis, to reduce the number of people who are in an immediate suicidal crisis, and also to reduce the risk of suicide in risk groups. Now I only mention the risk among people with mental illness, but also other risk groups are considered. Yeah, thank you for your presentation, for your attention.